Welcome to our September webinar. We are the ISBM, International Society of Bone Morphometry, and we treat all aspects of quantitative assessment of bone across scales. One of our activities is to host working groups. We have currently 4 working groups, which are HRPQCT, Advancing Protocols for Clinical Research, Spatial Transcriptomic in Skeletal Tissues, Prospects and Pitfalls, Imaging and Analysis of Nerves in Bone, and Bone and Micro and Ultrastructure Assessment Preclinical Models. If you want to know more about these working groups, do not hesitate to reach out. I am Mathilde Palmier, and I'm co-moderating this webinar with Ankita Agrawal. We are both members of the Early Career Investigator Committee, and we are organizing these monthly webinars. Our next one is on the 30th of October. It will be about tools for data management and reproducibility, and our invited speaker is Dr. Luke Johnson from Aarhus University in Denmark. If you want to stay updated about our latest news, then please follow the new ISBM LinkedIn page. It will also be an opportunity to stay updated about the upcoming ISBM meeting in 2026 in London. And we are putting together an exciting program. We can already announce that our keynote speaker will be Dr. Christa Maes. Finally, we would like to thank our 2025 corporate partner, AstraZeneca, for their support for the ISBM webinar series. So now it's time to welcome our speaker, Dr. Serkin Park. He is a professor and the chair of the Department of Biochemistry and Molecular Biology at Korea University College of Medicine in Seoul. He is an adjunct associate professor of medicine at Vanderbilt University School of Medicine. Dr. Park earned his DDS degree from Yonsei University in Seoul and a PhD in cancer biology at the University of Texas MD Anderson Cancer Center in Houston. He also completed a research fellowship on prostate cancer skeletal metastasis at the University of Michigan. And Dr. Park's research stands at the crossroads of bone biology, immunology, and oncology. He is particularly interested in the roles of myeloid lineage cells in the progression of bone metastasis and tumor microenvironment. Welcome, Dr. Park.
All right. Thank you so much for having me here today. I'm very delighted to have this opportunity to share my data and a little bit of my experience as a early stage investigator. So I'm going to share my slides now. Okay. So the title of my presentation today is the role of osteoblasts in breast cancer progression and bone metastasis. My name is Serkin Park again, and I'm at the Korea University College of Medicine, Seoul. So this is my disclosure. So when I started my research career, it was my dental school education. So I'm a dentist working on breast cancer in a medical school setting. So which is sometimes causes a little prejudice, but every time I make my career progression, I try to be logical. And of course, I was logical, but I wanted to be a little distinct so that each step I wanted to gain unique and distinct experiences. So the first dental school education gave me the expertise in hard tissue biology. And then I pursued my PhD in MD Anderson Cancer Center. And of course, among many cancer types, I chose prostate cancer because prostate cancer preferentially metastasized bone, so that I can combine my, so that I can make the best use of my dental background. And then again, I pursued fellowship in Laurie McCauley's lab at the University of Michigan, which involved a lot of bone marrow immunology. So combining these three components, I became independent, and my research stands on the crossroads of bone and immunity, which is the bone marrow immunity, and also the cancer cell biology. So the punchline of today's presentation is going to be the bone is the primary immune organ. So when you think of bone, you have to think of immunity. So this is mostly the bone group, so I emphasize the immunity. But when I talk to immunologists, I always emphasize that they have to think of bone when they think of immunity. So I'm going to show my data, both published and unpublished data, uh, linking the interactions among these three compartments. So my presentation is going to be three compartments, which is the first part is going to be the circulating osteoblast as a diagnostic marker for breast cancer bone metastasis. And the second part of my presentation is about a subtype of immune cells, which is a myeloid-derived suppressor cells in the bone marrow, and how they are regulated by the osteoblast. And then the third part of my presentation is going to be what can be the upstream factor of osteoblast that regulate the MDSCs in the cancer host. So breast cancer, the clinical aspect of breast cancer in Korea is a little bit different from the United States or worldwide. Here's the incidence rate among the age groups comparing Korea, Japan, and the United States. And the highest incidence of breast cancer is observed in the fifth decade of life in Korean patients, while the incidence is proportional to age in the United States or the Western countries. So we do not quite understand why Koreans get breast cancer at younger age, but the meaning of this data is that the South Korean patients have longer life expectancy after diagnosis of breast cancer, given that the South Korean women have the longest life expectancy in the world, and also that the South Korean patients have longer cancer survivorship after the 5-year follow-up. So, so early stage breast cancer patients eventually recur with bone metastasis within 15 years, according to this Canadian statistics. So if we combine all of these, bone metastasis may be a more important clinical problem in Korean cancer patients. So here's the brief scenario of bone metastasis progression. So younger patients have longer cancer survivorship. And then during this 5-year window after the initial surgery and chemotherapy, there may be multiple factors that can contribute to breast cancer bone metastasis progression, which I can divide into two groups. The first group is that the tumor intrinsic factors, which are more widely investigated, such as breast cancer subtypes. Of course, luminal type or ER/PR positivity are important in breast cancer bone metastasis progression, lymph node involvement, and of course, bone metastasis related genes mutated in the breast cancer cells. And of course, breast cancer express a lot of cytokines and growth factors such as PTHRP, BMP7, bone sialoprotein, etc., which all can contribute to the progression of bone metastasis. But I wanted to emphasize that the host factors, the changes in the microenvironment, I mean the bone marrow microenvironment, and maybe changes in the bone metabolism, anything that can regulate the osteoblast or osteoclast may contribute to the progression of bone metastasis. And then this process takes typically very long time. Let's look at the tissue since this is the ISBM, I wanted to share some of my tissue slides, this is the human prostate cancer cells growing in mouse tibia. And here you can see lamellar bone, which is the pre-existing bone before this tumor cell arrival. And here you can see multiple layers of osteoblast and woven bone, indicating the stromal cells are reacting to the tumor growth. And here you can see the very nice osteoclast here and here and here. And then you see a lot of immune cells in the bone marrow. So all this is the snapshot of very active dynamic interaction between the tumor and the host cells. And based on these tumor bone interactions, Dr. Greg Mundy and his colleagues demonstrated the evidence for the using osteoclast, which is a osteoclast inhibitors, which is mostly used as a osteoporosis, but that can be also used for the breast cancer patient. Bone metastatic breast cancer cells express growth factors such as PTHrP, and in response to this PTHrP, osteoblast proliferate and open bone formation, and then osteoblast, of course, express rank ligand and MCSF and promote the osteoclastogenesis, osteolysis, and then osteolysis releases growth factors from the bone matrix. So this is my microbone metastasis, which is recapitulating the earlier phase of the cancer survivorship. Here you can see when the tumor cells are very small, when the tumor metastasis is very small, which involves about a few hundreds or even less than the cells, they always stick to the endosteum, so endosteal osteoblast. And when they start to proliferate, which is like this, multiple colonies, when they form the multiple colonies, always osteoblast proliferation is accompanied. And in this massive osteolysis phases, of course, osteoclastic activity is more predominant, but this earlier phase, osteoblastic activity, precedes before the osteoclast formation. And there are other evidence from other investigators that the osteoblasts are important cells driving the metastatic progression. So osteoblasts produce cytokines and growth factors, which I showed before, the PTHrP and BMP, that are essential for the metastatic tumor growth, angiogenesis, and osteolysis, and so on. And osteoblast can provide the hematopoietic stem cell niche, and then that niche can provide the tumor cell colonization, early colonization, according to Yusuke Shiozawa and Ross Teichman group. And our data here is serial histology showing that the growth of micrometastatic breast cancer in the mirroring bone always accompanied by the osteoblast proliferation, indicating that osteoblast may be the important cell type in the bone metastasis microenvironment. Maybe they are the master regulator of microenvironment. So in this scenario, we focused on the early phase of bone metastasis progression, which is this micrometastasis. In mouse models, micrometastasis progressed to osteolytic phase within few weeks, but in human patients, this micrometastasis essentially remain as dormant for a decade or even 2 decades. And then certain biological cues wake them up and then start to proliferate. So we wanted to know how we can diagnose this micrometastasis, which are not detectable by this clinical imaging, PET-CT or MRI or CT. So we are focusing on this micrometastasis period. And we read a paper by Sundeep Khosla showing that human osteoblasts are circulate in the blood. So that was called circulating osteocalcin positive cells because these cells were positive for the osteocalcin, which is the osteoblastic marker. But Sundeep Khosla group demonstrated in his New England Journal of Medicine paper that the growing adult, when the adolescent rapid growth phase, circulating osteocalcin positive cells are increased. And subsequently, he demonstrated that certain clinical scenarios such as bone fracture healing, hyperparathyroidism, you see increased levels of circulating osteocalcin positive cells, which may reflect the microscale changes in the bone microenvironment. So we wanted to know whether this osteoblastic activity in the early phase of bone metastasis progression may impact on the circulating osteocalcin positive cells. Here we can see in our breast cancer patient blood, we were able to detect these osteocalcin positive cells. And in this blood smear here, we can see these cells are smaller than these cells are mostly 5 to 10 micrometer in diameter. And these are the hematopoietic cells, and they do exist in the patient blood samples. And then we dichotomized these breast cancer patients, which were recruited in the Seoul National University Hospital in South Korea. We had about 100 metastatic breast cancer patients, and we divided this patient into two groups, which are the bone metastasis positive or bone metastasis negative. And we were first at kind of very naive that we wanted to see the increased level of circulating osteocalcin positive cells. Of course we did, but the p-value was not very significant. And we were even more intrigued by this discovery that if we further dichotomize these patient samples into low burden and high burden bone metastasis groups, high burden bone metastasis group had even lower levels of circulating osteocalcin positive cells, and then only low burden, low bone metastasis group had a statistically significantly higher level of circulating osteocalcin positive cells in their blood. However, we did not give up, and we followed up this bone metastasis positive. We followed up these patients for 18 months, and then reevaluated their bone metastasis lesion by radiographic imaging. And here you can see certain patients had a progressive disease during that 18-month period, and certain patients had a stable disease, which means that their bone metastasis didn't progress. And then if you look at the osteocalcin positive cell levels at the time of diagnosis, which is 18 months earlier than this progression or stability, here you can see the very significant changes in the osteocalcin positive cells. These data support that the patient who had higher level of osteocalcin positive cells, their bone metastases are progressing, versus if they have lower levels of circulating osteocalcin positive cells, their bone metastasis may be very stable, and they may not need active surveillance or active treatment. And these circulating osteocalcin positive cells have very sensitive and very specific diagnostic tool to predict the progression of bone metastasis. And also, among these bone metastasis negative patients, we had de novo bone metastasis among these patients after 18 months, and these patients had already increased the levels of circulating osteocalcin positive cells 18 months before the clinical diagnosis of breast cancer bone metastasis. So our data here shows that the circulating osteocalcin positive cells may reflect the microenvironment changes in the bone metastatic microenvironment, and that microenvironment may shed the osteocalcin positive cells, which are the osteoblasts, from the lesion into the circulation, which you can use as a diagnostic marker for prediction, and also for prediction of progression, and also the prediction of the new bone metastasis. And as a mouse biologist, I wanted to reproduce the data in my mouse models. And here you can see bioluminescence are very sensitive tool to measure the bone metastasis or any metastatic progression. You can detect even as low as few thousand cells. Here you can see day 3 and day 5 after the intratubular injection. You don't detect the bone metastasis, but you already see the increase of circulating osteocalcin positive cells in the blood. And very interestingly, when the tumors enter this osteolytic phase, circulating osteocalcin positive cells start to reduce, which explains our clinical observation that the high burden bone metastasis group, which may who may have the osteolytic phase disease, have lower levels of circulating osteocalcin positive cells. So maybe osteocalcin positive cells or the proliferation of osteoblast or shedding the osteoblast into the circulation are all very specific to this micrometastatic period rather than the whole bone metastasis period. And here you can see, again, these micro serial sections shows that when this bone metastasis enters the massive osteolytic phase, which is day 11 and day 14, you see the reduction of circulating osteocalcin positive cells. But in this very early phase, which involves more proliferative osteoblast, you see the very significant increase of osteoblast, supporting our clinical observation. So this paper was published in the JBMR, and it was the collaboration with a breast cancer oncologist and an endocrinologist and a biologist, and it was published with this very nice commentary showing that we can provide the diagnostic tool for this early bone metastatic cancer patients. So far, I have demonstrated that osteoblast can be diagnostic, can have diagnostic value. And I wanted to know what the osteoblast play the roles, what kind of roles osteoblast play in the cancer bone microenvironment. And I focused on the interaction between the tumor cells and the environment cells, which are the bone marrow cells. And among many subtypes of bone marrow cells, I focused on the MDSC, which is the myeloid-derived suppressor cells. So they basically kill the T cells. So they are the bad guys, the corrupted policemen, protecting the tumor cells from the host immune surveillance. And these cells can be defined by combinations of surface markers, different from human and mouse. But even these combinations of markers are increasing, and MDS investigators have their own definition of MDSCs. But the important thing is that the MDSCs are not defined by the surface markers, but of course, these surface markers all overlap with other types of myeloid lineage cells, but the MDSCs are basically defined as a T cell suppressive cell population, which has to be determined by MDSC and T cell co-culture. And if you observe that T cells are dying, you can define these cells, or this cell population may contain the immunosuppressive population, which is the MDSCs. So during my postdoc research, I discovered that this PTHRP may increase these MDSCs, which fits this diagram that PTHRP may be the upstream of osteoblast, because osteoblasts are the predominant cells expressing the receptors for PTHRP. And then osteoblasts may increase or functionally activate the myeloid-derived suppressor cells and kill the T cells, promoting the bone metastasis. This can be one of the mechanisms how PTHRP promote the bone metastasis progression. But I wanted to know the link between these osteoblasts and the MDSCs, how they activate or how they contribute to the myeloid-derived suppressor cell function. And this is, again, my clinical evidence that no metastasis versus bone metastasis, you see very significant increase of monocytic and polymorphonuclear granulocytic subtype of MDSCs. So these data suggest that the MDSCs may be important cells in the breast cancer, at least in the breast cancer progression, but there are many other lines of evidence supporting the roles of MDSCs in the any given type of cancer. So the second part of my presentation will show this molecular mechanism, how these osteoblasts regulate these monocytic MDSCs, and then osteoblast activation basically cut these MDSCs tethering into the osteoblast and then into the circulation so that MDSCs can be can have more utility for the tumor cells. So this is one of the mechanisms how osteoblast can promote the cancer progression in the whole body, not in the bone metastasis, because MDSCs are universally important cells for the primary breast cancer and also for the bone metastasis. So the second part is focusing on the MDSCs in the systemic circulation and osteoblast playing the role for the systemic progression of cancer. So here you can see we had mice that were infused with recombinant human PTHRP or PBS for 3 weeks using this continuous pump, which is different from the PTHP as a osteoporotic factor. This continuous PTHP recapitulate the tumor cells' continuous expression of PTHRP. And here you can see in the blood, monocytic MDSCs are increased very significantly, but not as much as these tumor-bearing bones. Of course, tumor-bearing mice will have more significant impact on the MDSCs, but the PTHP alone, this growth factor alone, can mobilize these MDSCs potentially from the bone marrow into the circulation. And here, since this was the published data, I'm going to skip the details, but to make the time. Here you can see other bone marrow mobilizing agent, such as AMD3100 or GM-CSF, does not increase the monocytic MDSCs, but the PTH or PTHRP, which shares the PTHRP receptor PTH1R, promote the MDSC mobilization into circulation, supporting that the osteoblast may be the important cells in regulating the MDSC mobilization into the circulation. And this rapid manner, so if you infuse PTHRP, you see increased levels of monocytic MDSC in the blood within a very short time period. So it may not be the proliferation of MDSCs. We thought that it may be the mobilization of MDSCs into the circulation. And here again, MDSCs are functionally defined cells, and we co-culture these cells with T cells, and then we observe the T cell suppression. So PTHRP activated MDSCs can be truly MDSCs. And then we wanted to know the molecular mechanism, how this osteoblast can release the MDSCs into circulation. So we had this, we thought of this in vitro model, which is a unilayer of osteoblast. And then we isolated MDSCs from the tumor-bearing mice or cancer patient blood, and then co-culture them for 30 minutes. And then if we wash them, MDSCs bind to the osteoblast. So here you can see MDSCs do bind to the osteoblast, which is how MDSCs can be released by the osteoblast. And using this co-culture model, we added the PTHRP, and we see reduction of MDSC binding to the osteoblast. And here you can see in the mouse models and the human mouse, human model. And also, if you block the PTHRP receptor signaling, which is adenylyl cyclase inhibitor, or if you activate the PKA signaling, which is the downstream of PTHRP, you see increase of MDSC mobilization, which is the release of binding. So among all of these in vitro data demonstrate that maybe MDSC bind to the osteoblast, and then activation of osteoblast will release MDSCs into the bone marrow or into the circulation. And electron microscopic images demonstrate that this MDSC osteoblast binding is not simply the co-localization. It can be it can be mediated by the adhesion molecules. Here you can see. So we searched for the adhesion molecules between the MDSCs and osteoblast, and this murine histology data demonstrate that MDSCs do exist in the adjacent osteoblast endosteal niche. And then this binding can be of integrin beta 1 and BCAM1 tethering, so which is very common adhesion molecule for the any given type of hematopoietic cells to the stromal cells, and MDSCs do utilize this tethering mechanism to bind to the osteoblast. I'm not telling you that all of the MDSCs in the bone marrow exist binds to the osteoblast. Maybe a fraction of MDSCs or a certain portion of MDSCs do bind to the osteoblast, and then osteoblast may regulate only these cell types. So because PTHRP can be important factor for the MDSC mobilization, but PTHRP is not universally expressed by all types of cancer cells, but MDSCs are universally important cells in the cancer progression. So my reasoning here is that the PTHRP may not be the only factor that regulate the MDSCs, but it's one of the factors that can regulate the osteoblast and then change the immunity of the cancer patient. And subsequent data are all supporting how this tethering mechanism exists between the tumor cells and the osteoblast. And then what factors in response to PTHRP can regulate the MDSC tethering mechanism, which was the osteoblast released VEGF-A and IL-6. And then this VEGF-A and IL-6 hit the MDSCs and MDSCs become activated. So activation of MDSCs are indicated by this Serk family kinase phosphorylation. So indeed, if you give the Serk kinase inhibitor in this the PTHRP-induced mouse models, you see very significant reduction of MDSC mobilization into the circulation. So Serk family kinase activation in the MDSC may be the central signaling pathway for the osteoblast-mediated MDSC release into the circulation. And then we again, what can be the factor downstream of the Serk so that the MDS can cut the tethering from the osteoblast and then enter the circulation. And we discovered that this ADAM17 in human patient samples and also murine samples are very significantly increased by this PTHRP condition medium, supporting that ADAM17 can cut the tethering between the VCAM1 and integrin alpha 4 beta 1, and then cut that tethering mechanism so that they can enter the circulation. And then we confirmed that using the Serkin inhibitor again. And then ADAM17 blockade blunt or the reverses the effect of PTHRP and MDSC mobilization, supporting that these SHEDAs maybe play the important role in the osteoblast-mediated systemic immunity changes. So to summarize my data, osteoblast may regulate the systemic immunity. One of the mechanisms can be releasing the MDSCs into the circulation in cancer patients. Upstream of osteoblast can be many factors. One of them can be PTHRP or other cytokines or other factors that may affect the osteoblast, such as aging or any changes in the osteoblast proliferation or activation can change the immunity. That's why I told you in my first slide that think of bone, think of immunity type. So one clinical insight from this data can be anything that may affect the bone anabolism, such as teriparatide, may impact on the immunity or occult tumor metastasis or change the efficacy of immune checkpoint inhibitors, which have never been investigated seriously in